Lafayette Regional Vein Center became an opportunity roughly 3 years ago. And since that time, we have been exclusively dedicated to managing the entire spectrum of venous disease, but we've employed a lot more treatment options. From my initial exposure to sclerotherapy and thermal ablation, we've added radiofrequency, we've added microphlebectomy. So we can really manage the entire spectrum of vein disease that any patient presenting through my door. Having this spectrum of treatment options that we possess allow us to tailor a lot of different treatment options to a given limb, so we can optimize the outcomes. We're never left without a treatment option when it's all said and done. So what we have done, every patient that comes through the door offers a unique opportunity to evaluate their given venous concerns. Every leg is unique. It's very rare that we see a mirror image, from one leg to the next. And patients' desires, what they're looking for in an ultimate outcome, varies as well. And it's important that we identify what their concerns are, educate them about their treatment options and what it's going to take to get a durable outcome. And that's what we've really thrived on. I'm real blessed to have a nurse that I've worked with now for 4 years. I have an office manager who understands the importance of avoiding financial surprises for our patients. When it comes to that first evaluation, we verify benefits. We identify for the patient what benefits they have available to them and make sure that they understand the medical necessity criteria. So that's kind of the administrative and my assistant nursing staff. When it comes to the office is intended to be a comfortable, enjoyable place to be. It's not the traditional office setting. The colors of the office, if you will, are relaxing colors. We have the ability to put on music in the treatment room so the patients can be relaxed. They can bring in their own MP3 player if they like, so they can listen to their own music. The patient comes into the office, they're greeted by our staff. Within a few minutes of filling out paperwork, they're brought back to one of our large vein treatment rooms. That room also serves as a consultation room where we employ duplex diagnostics. After further history about the patient's venous concerns, our treatments they may have had, certainly the symptoms that they currently present with, and any conservative therapy that they've tried, we then employ duplex diagnostics so we can use ultrasound to sort out the extent of disease in a limb. In my rooms, we actually have 42-inch plasma screens on the wall so that the patient can watch in real time what we're seeing with the scan and have a better understanding of what's going on deep to the surface. I wouldn't expect patients to necessarily understand ultrasound when they leave the office, but I would expect that given the time we take to show them in real time, whether a vessel is diseased or not based upon spectral waveform analysis or color Doppler, that they'll leave the office with a true understanding of what's going on in their leg and essentially ownership of what's going on. Many patients come in with just a branch below the knee that they're concerned with and have never really thought that it may be attached to a diseased great saphenous. When you can put that whole picture together and then discuss the treatment options on how just treating this would likely not yield a long-term outcome and certainly wouldn't provide sustained symptom control, it puts everything together so that the patient really understands what has to happen from there. So after that assessment, our office manager has a chance to go in and speak with them about insurance benefits, or if it's purely a cosmetic patient, they have a full cost estimate based upon the extent of disease. If it's a particular insurance carrier that has a particular medical necessity requirement, we just educate the patient on what it's going to take. Some of the insurers may require 6 months of compression. Well, if that's the case, we're going to educate them on that 6 months of compression if they want their insurer to do their part, and we'll get that started that day. And in the meantime, we follow up after that encounter, so we monitor them, how they're doing with the compression, and when that 6 months is over, at that point we submit things to the insurer and help them at that point. Generally speaking, a patient comes in and if they're having a thermal ablation procedure or a sclerotherapy procedure, they can be in the office typically no more than an hour, hour and a half, and then they're up and walking and on their way. There are some times where we may ask patients to elevate the leg after a large ambulatory phlebectomy case or something like that where there might be risk of hemorrhage if they were up and walking, but otherwise patients have very limited downtime and very little discomfort after what we do. I currently employ a second-generation laser, 1319 nanometer laser to help manage saphenous veins, and I've added radiofrequency closure fast as well. I have two devices that I believe are better for our patients in their recovery. I truly believe that any heat source in skilled hands can close a vein, but I really am glad that the two devices that I have lead to far less bruising, far less post-recovery discomfort. We have both the vein viewer, which was the 2004 invention of the year. It shows incredible detail. In fact, in some vessels that you just couldn't see with a vein light, but we transilluminate the skin, so whether it's with a vein viewer or whether it's with a vein light, we're able to deliver a better outcome for even patients with surface sclerotherapy. When it comes to phlebectomy, phlebectomy's been around for a long period of time. That's where you make small incisions and you use hooks and physically remove the vessels. I think what's changed is, years ago, those incisions were this wide. Hooks were a little bit bigger. Thanks to a tip I picked up in a conference last year, using a small ophthalmic blade, my incisions are incredibly tiny. Using small hooks, I can remove 32 centimeters of vein in about this much area. It was just a big cluster back and forth. We removed it all in one segment through 5 small little incisions. If I inject that vessel, I can make it go away. It just takes much longer to get that job done with a lot more soreness. I've already spoken to that patient today. That area is not even sore. It's bruised, but it's not even sore. And her incisions, she's not even going to be worried about, 3-4 weeks from now.